Hello everyone, thanks for everyone for coming and welcome to all the Zoomers. It was great to have the international presentation as well. My name is Jack Nagle and I'm a member of the working group. Now thankfully we're running a little bit short on time because Robert Alai gave me a bunch of jokes and they're terrible, so we get to skip over those and miss them. But I'm excited about today's first session, which is New Directions in Pharmacotherapies for Methamphetamine Use Disorder. And yeah, we won't waste any time, but it should be a dynamic session because we're covering a lot of different sections of the methamphetamine withdrawal process. And yeah, we've got a lot of different topics, including women and youth, which are underrepresented in the literature, so it'll be good to hear from all the speakers. So first up, we've got Professor Shalini Arunogiri. Is that, I hope I got that right. I asked for a name previously. I think I messed it up. So come on down, mate, and yeah, tell us what you're presenting on. Thanks.
Hi everyone in the room and also everyone who's online on Zoom. Pleasure to be able to do the first abstract kicking off this morning's session, and just wanted to acknowledge traditional owners of the lands on which we're meeting today, and also across Australia and New Zealand potentially on Zoom. Today is the first time I think we've had an opportunity to meet in person with the NCCRED kind of team for 2 years plus, so I think really just an acknowledgement of the fact that this is just such a tremendous capacity to actually come here and listen to all of the amazing projects that NCCRED have been able to support, including this study. So I wanted to tell you a bit about this study that was funded, I think, in round 3 by NCCRED, which was back in 2019, as I was saying to some people this morning, that was pre-pandemic. And so that's really had some impact on this study, as I no doubt will hear has had impact on several studies today. But really glad to be able to come to this point, I think, with this study and many of our other clinical research projects, and be able to share what the future, I think, looks like. So I'm from Melbourne or NAM, and our project is based on oxytocin for methamphetamine withdrawal in women. Just a kind of disclaimer that the work today has been supported by NCCRED, and I'm supported by an NHMRC Emerging Leader Grant, and also a number of other sort of grants that are unrelated to this work, and also acknowledging the team that's kind of been working on this project for on and off for nearly 2 years to be able to kind of support this coming to fruition at our team in Melbourne. So just a little bit of an overview, a flying overview given our time scale today of oxytocin and what the chemical is and what it contributes to. Some people might be familiar with this. It certainly gets a lot of press, this chemical, because it's often referred to as sort of the love hormone or the cuddle hormone. Clearly a very reductionist kind of approach in terms of a highly complex chemical. It's a naturally occurring neuropeptide. And we know of oxytocin from a range of different kind of medical approaches. So it's a medication that's used in labor or delivery to induce kind of labor in an intravenous formulation. And it's also part of our natural process in terms of the letdown reflex, in terms of breastfeeding. And so in the context of breastfeeding, that's actually a process that cannot occur without oxytocin's presence. Whereas there are a lot of other kind of behavioral responses, a lot of different things that kind of happen that can happen without oxytocin having an impact. But it does occur in terms of being able to kind of have an impact on social cognition, for instance, how we relate to other people, how we might bond with other people, particularly in group settings, and how we relate to other people at different parts of our lifespan. So in terms of our interest in oxytocin, as you can see here, this is just to give you an overview of the fact that it is produced in the hypothalamus and then it goes throughout your brain. There are actually receptors in a whole range of different brain areas, and there are also receptors throughout the body as well. So what we know is it's produced centrally in the brain, but it also kind of goes throughout our body systems and has kind of subsequent impacts on a range of different organs across our body. For us, in terms of substance use disorder, our interest in this kind of arises after sort of probably over a decade of research into oxytocin's kind of capacity to have downstream effects on behavior in particular. And people might be familiar with some of the mental health research that's been done in this space, including in disorders that kind of impact on our capacity to relate to other people in particular. So for instance, autism spectrum disorders and other disorders that have mental health impact. So in substance use disorders, there's an alteration in sort of oxytocin signaling across a whole range of different responses, including the reward pathways and including pathways that intermediate sort of with stress responses in particular. So those are clearly two very salient sort of circuits in addictions, but particularly for people in that context of that withdrawal response and the relapse response. So for instance, when people are continuing to use and stop using, in that period after using, what happens then? So in that recovery period, in terms of people being able to have kind of that effect on both bonding and social kind of recovery, but also on the other hand, that capacity to be sort of vulnerable to particular triggers that might arise during that period. So these are two particular periods where we think oxytocin could play a role. In this particular study as well, we were interested in oxytocin in terms of the capacity to actually have an effect on behavioral responses in women specifically. So our study is only being done in women, and this is really based on both preclinical evidence and sort of snapshot sort of in the lab evidence with humans to suggest differences in responses in males compared to females. There have been existing studies with oxytocin in men, in adult men, but in those studies, they have been male-only studies, and so we thought, let's look at a female-only study to understand whether these differences in responses that we're seeing in the lab and in animals actually ever play a role in humans. So, as I was saying, there have been very few studies to date in addiction, and specifically in methamphetamine. I've just snapshotted a couple of studies from the US by Christopher Stoffer's group that have been done in a male-only population, and men have sex with men. And so these two studies, it started, I think, in 2019 and has been subsequently completed, and they've gone on to do a couple more studies. And in these studies, what's really interesting is the use of oxytocin here as an intranasal drug, and it's actually specifically being used to support psychosocial treatment, which is a really interesting approach, I think, particularly for methamphetamine use, where we know that psychosocial treatment is kind of our gold standard, our backbone of highly effective treatment approaches. The role of this chemical is really about being able to support or bolster the psychological treatment approach as well. So for us, this is a specific study in that withdrawal period in women. So for instance, people coming into an inpatient detox for a 1-week period, and we're looking at specifically withdrawal symptom severity, but our treatment and our endpoint is treatment retention. So we know that in Australia particularly, that we know that people who come in for a detox from methamphetamine often don't stay very long. I think nationally our kind of average or median length of stay are somewhere to sort of about 3-day period. And that's probably not good enough. I think we know that often detox is that first step point to rehabs or to other kind of psychosocial recovery programs. So we want to be able to retain people as long as possible. And so this is one approach to kind of see whether we can actually boost that. But in the context of, a very small pilot, we're looking at specifically whether there's any sort of signal, but really mainly about feasibility and safety in this pilot, about being able to administer oxytocin intranasally twice a day for a 7-day period. And so the primary endpoint of our study, as I said, was retention, but we're also looking at a whole range of secondary outcomes, including, as I mentioned before, trying to understand how people bond with each other in the detox setting as well. Rapport and engagement with the treatment providers, so for instance, with the people in the detox, the nursing teams, the medical teams, and with subsequent kind of engagement in the psychosocial programs that people are being linked into post-detox as well. In terms of this study, and coming to you talking about this study sort of 2 years post-funding, and I think acknowledging the fact that studies like this are very hard to kind of set up from scratch, particularly in the context of COVID. So for us, we had lots and lots of woes along the way. Our ward that we're planning to run the study to got commandeered and became a COVID ward specifically for a long period of time, and hopefully we'll get it back. But also we had a significant disruption trying to access drug supply. And so, this might come out in some of the other pharmacological studies we talk about today, but I think accessing investigator-initiated drug supply for studies is really challenging in Australia. We don't need a lot of medication, we just need a small amount of medication, and for a lot of pharmaceutical companies it's not worth their time to sort of supply. So that was a huge challenge for us to be able to access the amount of medication we needed for a study like this. But that being said, we do have medication and we do have a ward, so we're planning to start this in a couple of weeks actually, so we're about to launch the study in Melbourne. So if people have clients or friends who are interested to participate, please send them along. And I guess in terms of positives, just wanted to kind of really acknowledge, I guess, the impact that this study has had on our own research teams and our own clinical teams at our clinical site. The main aim of going for grants like this was to be able to kind of upskill our research teams, but also our clinical teams, and start to foster sort of research culture within our clinical workplace, including our detox. And the study's really helped with that. I think people are sort of interested and engaged in sort of that process, but also setting up those processes that are intrinsic to being able to run studies like this across drug and alcohol services. That's been pretty critical. So I might leave it there unless people have questions. Please come and approach me during tea, I think, but we might, in the interest of time, and my email's there as well. Thanks very much.
Apologies, everyone, in the trying to get the show on the road and hearing all the great research. I forgot to mention that we'll have 3 minutes of questions after each presentation. So everybody asks plenty of questions, and that goes for people on Zoom as well. You'll get bonus points in your career, I promise. So does anybody have any questions for Shalini?
How are you doing? Cheers, Simon.
Thanks for your presentation. Simon Lenton from Indri in Perth. Is the medication an available medicine currently, or is it has to be made up for the trial?
No, it has to be made up for the trial. And so with any investigational drug such as this one, that's the challenge, as I was kind of pointing out, and accessing supply. If it is something that we can access, then we can, easily make that up. But I think this is, a real challenge when we're trying to look at emerging kind of options. Yeah.
Hi there, Claire Harper, New South Wales Ministry of Health. I was just wondering about your inclusion criteria and whether you were going to exclude people that had alcohol and other drugs besides methamphetamine, whether you're going to include those.
Yeah, thanks. And this will probably come up across all of our studies. I think the inclusion for this specific study, we've been relatively pragmatic. So we have methamphetamine, but also nicotine or cannabis use as part of the inclusion, but other substance use disorders where there's a severe or moderate to severe kind of substance use disorder, that is an exclusion. And this is a real challenge when we're doing sort of single disorder kind of research, which I don't think is necessarily representative of the people we see coming in through the door as well. But this is the very first initial study, so we just want to see if it helps.
There are a couple online questions that we have over here. We have Caroline Salem. She's congratulated you on your talk, and she's keen to hear about how you're working with the clinical team on the research capacity development overall.
Yeah, thanks, Caroline. So with this study, I think, as I was saying before, trying to actually put in studies into an existing kind of research naive or environment where there isn't kind of that capacity, I think it's starting to understand, I guess, for clinicians what their workflow is like and how studies like this can fit into their workflow, what the resources are specifically that people need. And also, I think, understanding from a client perspective, we've spent a lot of time we have a lived experience research as part of our investigator team, and we've spent a lot of time trying to understand from a clinician workflow, but a patient workflow in terms of people coming into our service, where is the best place to kind of put in both eligibility criteria and kind of, flyers and things, but also matching that into, say, a detox pipeline. That's super challenging, and I think it's probably challenging across kind of services, but I think being able to understand how you basically streamline mainstream services into being able to have amenable kind of processes has been really part of the process in setting up the study.
Excellent. And we have one more just about the eligibility criteria for the study. This is from an unknown respondent who's requesting to know if pregnant or breastfeeding women are eligible given the effect on birth or breastfeeding.
Yeah, no, they're not eligible. So people who are pregnant and breastfeeding, but also of childbearing potential, we'd be asking people to actually be on effective forms of contraception, because this is, as mentioned before, it's an investigational product. So, the dosing that we're using, the way in which we're using it, it hasn't been trialed in people who are pregnant or breastfeeding. And as mentioned by our respondent, there are clear kind of pathways that are going to overlap here, so we don't want to cause any harm. Okay.
Thanks for that. Okay, so next up we've got Bedi, Professor Gillinder Bedi, presenting on pharmacotherapies for methamphetamine use disorder in young people, ketamine and cannabinoid oil.
Thank you. So my name is Gillinder Bedi, and I'm going to be presenting on two studies that have been funded by NCCRED, close, that were funded by NCCRED as part of, I believe, funding round 2 and 4. Looking at candidate pharmacotherapies for methamphetamine use disorder in young people, specifically ketamine and cannabidiol. So I would also like to just acknowledge the traditional owners of the land on which we're all meeting, and also acknowledge that the work that was done in this presentation was done on Wurundjeri land. And we have no conflicts to declare. So just in terms of a general rationale for our research program, we are interested in substance use in young people more broadly. So I lead the substance use research group at Orygen. And our interest in methamphetamine use really came from a couple of different things. One is that methamphetamine use has the highest prevalence in young people aged 20 to 29. Working as I do at Orygen, we have a big focus on the earliest possible intervention or treatment, and so our interest is also bringing that to the substance use space. And at the time that we started this research program, methamphetamine use was the third highest primary drug of concern for young people presenting to alcohol and other drug services across Victoria. So in theory, that should have meant that we wouldn't have any problems with recruitment. So as we've already noted, there's no approved pharmacotherapies for methamphetamine use disorder. And just again, as a bit of a context, many of the young people presenting for substance use to treatment services have pronounced psychosocial complexity. And so from that perspective, we really view pharmacotherapies as a way of bolstering the effects of psychosocial and psychological intervention. So ketamine is a non-competitive antagonist at the glutamatergic NMDA receptor. It's a very well characterised substance, which is an advantage for us. It's been used for decades in anaesthesia. It's also being used very commonly in sub-anaesthetic doses for depression, as most of you would be aware. The hypothesis is that it may normalise glutamatergic dysregulation that is seen in the development of substance use disorders. So that's the hypothesis. Obviously, we don't know what's actually the mechanism here. Potentially facilitating new learning. So the ultimate treatment goal would actually be to use a combined model of ketamine with psychological intervention. Because we're starting with just a feasibility and safety trial, and because we had relatively limited resources, we're working with just the ketamine at this stage. So one of the other things we're excited about with ketamine is that coming from the United States and also the UK, there's some really exciting evidence suggesting a good signal for efficacy of ketamine, 1 to 2 infusions of ketamine plus psychological therapy for alcohol and cocaine, which obviously is very closely similar to methamphetamine use, although not the same. And there has been no previous research in methamphetamine use disorder. So the MASCOT trial, which is methamphetamine use in young people, sub-anaesthetic ketamine open label trial. It's obviously an open label design. We're recruiting 20 young people for this study between the ages of 15 and 25 years with moderate to severe methamphetamine use disorder. And our recruitment pipeline is very varied at the moment, so we actually don't treat people at our clinical services normally for methamphetamine use disorder. We do see some people at our headspace, but it's relatively rare. So we're recruiting via online mechanisms, we're recruiting via our existing partnerships with alcohol and other drug youth services, and we're constantly growing our partnerships with the local services, and also by word of mouth. So our primary aims are safety and tolerability, and we're operationalising safety as essentially change in ketamine use frequency and craving at week 6 from baseline. So our major concern for safety with ketamine is around the abuse liability of this substance. We obviously don't want to be introducing this substance to young people who are using methamphetamine and have them increase their ketamine use or even take up ketamine use. We're also looking at liver function tests at week 2. And then in terms of tolerability, we're looking at the number of participants withdrawing due to adverse medication effects. And we also have a secondary endpoint, which is preliminary efficacy. Obviously, in an open label trial, we can't determine efficacy. So we're just looking at correlates, essentially. So we're looking at the frequency of methamphetamine use at follow-up visits compared to baseline, and also looking at quantitative urinalysis. So this is what the study looks like. Participants enter the study, they undergo comprehensive screening, then they do a baseline visit, and at that point they have 2 ketamine sessions which are being conducted at the clinical trials unit of the Royal Melbourne Hospital, separated by at least 7 days. Then we have follow-up visits within 48 follow-up phone calls within 48 hours of the sessions. And then we have 3 follow-up visits at day 21, day 28, and day 42. So, to date, we have enrolled and completed 2 participants. Both of them have been female. One was 22, one was 25. Both used methamphetamine daily. So, in terms of safety in this very preliminary data set, we have seen no change in ketamine use. In fact, no ketamine use during the follow-up periods. No change in LFTs, so it's looking like we're getting a good safety signal at this very early stage. In terms of methamphetamine use, one of them stayed the same, one cut down a lot. Again, you can't really conclude anything from 2 people. Tolerability was fine. We didn't see any withdrawals and no serious adverse effects. So this is just a peek at some very, very early data on the subjective effects of the ketamine in these 2 participants across the 2 sessions. So this is measured using visual analog scale drug effect questionnaires, and these are proxies for abuse liability measures. So we essentially have in yellow, we have the like drug rating. So they're essentially rating repeatedly over the session. Sorry, yellow's feel drug, not like drug. Essentially rating over the session whether they feel any effects of the drug. Green is whether they like the effects of the drug, and orange is whether they would like more of the drug. So what we can see here is essentially we got very high ratings at the 15-minute time point, which we're actually a little bit surprised by, because that is again, it's only 2 participants, but that's more than we would see as the maximum point in something like an acute MDMA administration paradigm. So it was a little bit surprising. And we're seeing it drop off relatively quickly and return to normal in terms of whether or not they can feel the drug by the end of the session. So we did see a bit of a bump in liking of the drug, so they both liked the drug to some extent, and we did also see a bit of wanting more of the drug. So all of those things are abuse liability signals, and perhaps not surprising in this population that we would see those kind of effects. However, as I said, we haven't seen that translate into any use of ketamine. And moving now onto our second pilot study, which is a study focusing on cannabidiol, or CBD. CBD is a non-intoxicating cannabinoid, and it has a range of putative effects, including anti-anxiety, antipsychotic, which is the best established of the effects, and antidepressant effects. The mechanism in terms of substance use disorders is not specific, so it's being examined for a range of different substances, including cannabis use disorder, opioid use disorder, cocaine, and nicotine, cigarette smoking. The data that we based this on was really on animal models, so preclinical models showing that it reduced methamphetamine self-administration and relapse in an animal model of methamphetamine use disorder. So there was, following our submission, following the start of this study, there has been a study published in cocaine use disorder, which showed no effect on cocaine use. So it was a null finding. It's the first largish clinical trial of CBD for this indication. However, we think this might have been due to the dose. It was 800 milligrams, which we think might be just sub-efficacious for this indication. And there have been no published clinical trials for meth use disorder, although we know of a couple of pilots that are ongoing now. So the CALM study, which is cannabidiol, a novel pharmacotherapy for lowering methamphetamine use, and I'd also like to acknowledge the RAs who came up with these acronyms via competition. It's an open label study. It's N equals 12 young people between same age, but we're including mild to severe methamphetamine use disorder in this study because the risk-benefit balance is a little bit different to ketamine. Recruitment is via the same pipeline as Mascot. So very similar primary aims. Primary aim is safety and tolerability, which in this case is being operationalised as liver function tests at week 4 and 8 relative to baseline, and number of participants withdrawing due to adverse medication effects. Secondary is preliminary efficacy based on change from baseline in frequency of methamphetamine use and craving for methamphetamine. So this is what the design of the study looks like. Participants, again, go through that comprehensive screening and then a baseline assessment. Then they are on maintenance on the CBD, starting at 800 milligrams daily and going up to 1,000 milligrams daily. So just as a context, it's vastly higher than what might be available. I don't know how many of you have seen the over-the-counter preparations available, particularly in the United States. Typically they're around about sort of somewhere, if they have any CBD in them, they have 25 to 40 milligrams of CBD in them. So what we're using is vastly higher than any of those preparations. So they undergo 8 weeks of maintenance and then a follow-up visit at week 12. So in terms of our progress for this study, so we have an existing common screening recruitment pipeline with Mascot. We're currently finalising ethics approval and governance. Now we have run into an ethics approval issue, which is too boring to even talk about. If anyone is really interested, they can come and talk to me afterwards, but we have a hope that we will be dealing with this in the next little while. We have the investigational product, which is, in the case of CBD, actually very hard to organise, so we're very pleased that we have got it. And recruitment will be commencing early next year, ethics willing. So we've also obviously had some recruitment issues, and I'm just highlighting here 2 people who are currently really key in the recruitment process. So Alex Gurin, who is leading this research program, who's an ECR, and then Lee Clamett, who is a PhD student who's also helping us with recruitment. Obviously we had COVID in Melbourne particularly, we had a lot of COVID. We have been advertising via social media with limited success, and we have tried every avenue under the sun. Interestingly, we've had actually quite a lot of people fill out the expression of interest. It's just not converting to people actually following through. So we literally don't get an opportunity to talk to them. So they send in the information and then vanish off the face of the earth. So it's actually quite difficult to work with that pattern because we don't know if it's anything we said because we didn't really say anything. So, but we think that it's probably representing a degree of ambivalence in this population because we find that we're getting expressions of interest, for instance, at 2 o'clock in the morning. By 11 o'clock the next day when we call them, that someone is no longer interested, essentially. So we are currently expanding our recruitment locations and methods. We're revising all of our recruitment materials, and we're hoping to be allowed to include the financial compensation amount on the actual recruitment materials, which we think might actually be a part of all of this because we are actually asking quite a lot for people in terms of showing up to things. We're also potentially considering removing that people have to have a desire to reduce their methamphetamine use as one of the criteria. But again, we don't even get to the point of actually finding out if they want to reduce their methamphetamine use because we don't have a chance to talk to them. So we're not totally convinced about that one. So in summary, obviously pharmacotherapies for methamphetamine use disorder are needed. In an ideal world, we would be intervening as early as possible amongst young people. We know this often starts in young people, and people obviously spend a long period not having treatment before they finally decide to have treatment. Ketamine and cannabidiol are both relatively promising candidates. My favourite is ketamine at the moment, but CBD still has something to be said for it. And we have recruitment challenges in young people, which hopefully by next year we'll have sorted out. So thank you.
I reckon if anyone has one, we can fit in one question on that.
Thanks for the presentation. Gillinder, my name is Tarun. I'm a specialist with the Drug and Alcohol Services in Newcastle. Just a quick question regarding the ketamine trial. Are we monitoring the mental health symptoms like depression as well for these clients? Because ketamine can have an antidepressant effect in the first session, and that reinforcing effect, the liking of the drug, could be relief of depressive symptoms rather than drug liking in an addiction sense. I'm just not sure.
So super interesting question. We are getting that data. So one of the things in the mental health field is that people don't typically measure the acute drug effects, and so what we're getting there is an acute drug effect essentially. So the fact that so it's literally a single scale saying, do you like the effect that you're feeling now? So my guess is that it's probably a mood effect. There's a mood component to that, obviously, like they're feeling high, which, you know, it's hilarious because when I've discussed this with the mental health researchers, they're all like, oh, no one likes it. it. But I mean, our people will like it. So I think we will have interesting data on that, as those aspects as well, at all of the follow-up visits. We haven't looked at it yet, and I would think that probably the mood effect is dissociable from the antidepressant effect.
Thank you.
Thanks so much. Okay, thanks a lot for that. Next, we have Dr. Elizabeth Nock presenting on psilocybin-facilitated treatment for methamphetamine dependence, a pilot study.
Hi everyone, I'm Liz. I work as a clinical psychologist at St Vincent's Hospital, mainly in the stimulant treatment program, and I'm an investigator on the Psi-MA study, which I'm here to talk about today. So first of all, just a quick acknowledgement to the team behind this study and getting it off the ground, and of course thank you to NCCRED for the support. Okay. So you're likely aware of the growing body of research that shows promising signals in psychedelic, particularly psilocybin-assisted psychotherapy, mainly originally explored in depression and now expanding into other areas. So I've just put the important papers in addiction on the slide, mainly looking at alcohol and tobacco. So at the moment, these are small open label trials that are showing promising results, and they're moving into larger randomised double-blind trials at the moment, so there's quite a space to watch here. And so why methamphetamine right now? Early studies in the field are spreading a pretty wide net across a number of indications, so addressing mental health and different forms of addiction. And so if psilocybin-assisted psychotherapy is in fact found to be useful, it makes sense that there's some fairly core mechanisms of action that are perhaps going on here across all indications. So transdiagnostic treatments are obviously always a good idea. And in methamphetamine use treatment, we know that comorbidities such as depression, anxiety, trauma, are really common. We don't treat them very well altogether, and we know that this has an adverse effect on treatment outcomes. Psilocybin's pro-social effects, an increased sense of connection, is often talked about. So this seems particularly important in methamphetamine use disorder, where we know that loneliness and a lack of connection is often associated with poorer treatment outcomes. And interesting, obviously, that temporary sense of connection to others that comes with methamphetamine use is actually one of the more attractive features sometimes that users report. So it was really interesting actually to hear earlier the reference to oxytocin and bonding and social recovery, because that really does stand out for me as something we work with in often that withdrawal phase or prolonged withdrawal phase. So increases in psychological flexibility is another commonly talked or hypothesized mechanism of action, potentially due to increased neuroplasticity. I'm no neuropsychologist, but I do know that psychological flexibility is something that's often an overarching goal of the psychotherapy treatments that we're working with. And so particularly in methamphetamine users seeking treatment, where rigid thinking, maladaptive behaviour patterns, impairments in mood and cognition, often persist for a really long time in that prolonged withdrawal period that we're all aware of. So there's currently 3 other studies worldwide looking at stimulant treatment in this area. In Portland, Oregon, they're trialling PAP in an inpatient setting in an Army veterans VA rehab hospital. It's quite different to our setting. They're preparing to start recruitment in Wisconsin in an outpatient model quite similar to ours. And in Alabama, Peter Hendricks has nearly completed recruitment of a trial with cocaine users. This has been really interesting to watch. Peter's population of cocaine users is probably socio-demographically the closest to ours at STP, which is perhaps surprising, not culturally similar, but socio-demographically similar. And his is a population that comes with less chance of preconceived ideas about psilocybin or psychedelics in the first place and less expectation. So really interesting to see what happens there. So our trial, the Psi-MA trial, is an open label, single arm design, and our primary objective is, of course, safety and feasibility at this stage as well. In line with other trials in the area, we are looking to collect some secondary data as well, so relating to substance use outcomes and a number of other measures of quality of life. well-being, that sort of thing, and then measures that are potential mediators, such as connectedness, let's talk about the psychedelic experience itself, the intensity, avoidance, and quite a few more. It's a very brief summary there on the screen. Okay, so our inclusion and exclusion criteria up there on the screen is mainly focused around excluding those that are at risk of psychosis, regular use of alcohol, cannabis and other hallucinogens, and also obviously focusing on capacity to attend the sessions and be supported in their home environment after the dose day. So this is our full schedule of study visits. As you can see, the majority of face-to-face takes place within 1 month leading up to the dose day and 1 month after. The PrEP psychotherapy focuses on building alliance, practical elements, getting ready for the dose day, setting an intention, so that's what the participant would like to get out of the process, and building support for substance use change, so motivational interviewing that we all know. The dose day itself is an 8-hour non-directive session with a therapy dyad, so it's always with 2 therapists in this model, at the moment anyway, and with a 25 milligram dose of psilocybin. An integration psychotherapy identifies any useful experiences taken from the dose day, such as enhanced motivation, which is something we're always looking for, and explores ways to sort of revisit these and bring these back to the forefront of the mind. And then really practical strategies to enable change, and maybe familiar territory for us, relapse prevention, behaviour activation, that sort of thing. Right, I'm going to skip over these ones for time. So considerations to this point. Much like others, one of the biggest challenges we had was getting the drug in the country in a timely fashion. In fact, it took so long that I had time to go on maternity leave and come back. But we're there now, we've got it. So with most studies moving in and out, just moving out of safety and feasibility, we're really looking at really early stage 2 trials at this point. So we're nowhere near having an evidence base for the best models of psychotherapy. That obviously takes a bit of a back seat. So it's fair to say that what we're doing at the moment is a best guess. Most models combine psychedelic therapy, essentially taken from what was sort of the underground models in practice, so no evidence base, and combine that with what we know to be safe and effective in the populations that we're working with at the moment. So for us, that means that we've built a team of therapists from both within and external to St Vincent's, which hopefully means that we've got a good mix of addiction skills and others with a bit more substantial training with background in psychedelic therapy. Typical patterns of methamphetamine, I think, may pose problems. Obviously, the need to reduce use or stop use a few days prior to the dose day, but also wanting to avoid having that sort of final prep session and dose day in a pretty significant period of withdrawal has the potential to be pretty challenging. We know that. So maybe, in future trials, detox might be something that needs to be considered. Okay. Well, we've got our first participant, which is very exciting. And so we've pre-screened a number who have been ineligible. So to this point, less than the 16 days of use methamphetamine use within the month is potentially prohibitive. It's definitely, it's very kind of, sledgehammer definition of methamphetamine use. And we're only using that really for the safety benefit around psychosis use, and we're probably not getting a lot of benefit from that really. So it'll be interesting to see what we decide there. For us, SSRIs and SNRIs are not an exclusion criteria, but there is good reason why other studies have excluded these. Originally, an audit of STP clients suggested that there weren't a lot taking these medications regularly and it wouldn't be a problem. But really interesting now that we're pre-screening and we've added that filter of less than 16 days in the month, of course it does make some sense. That might be a population who are slightly more able to regularly take prescribed medications. Similarly, that filter of less than 16 days in a month means that participants who are eligible, there's a strong chance that they're actually in employment, and this is quite a resource time heavy study, so we'll watch that as well. Could be a bit of a stumbling block, and it's really early days, but STP clinicians have flagged that perhaps that safe home environment and a supportive person is perhaps one that we didn't so much predict coming as a stumbling block to referring. And I guess if that proves to be the case, it only reinforces the significance of that connection and sort of lack of social support in this population, which, you know, continues to be really relevant to think about and talk about. So I'll leave you with a picture of our very nicely set up, I think, and very unusual for our service, psychotherapy counselling room.
Is there any questions? Just up the back first.
Thank you for that presentation. I'm interested in what factors are taken into account when selecting the therapeutic dyad and how the role is balanced between those therapists.
Okay, yeah. Really good question, because we've turned it over a load. And of course, unfortunately, I think pragmatism often wins out. So we've got what would be ideal, and then we've got what's practical in trying to pull off a study. So, you know, we've talked about, you know, typically it was always this really sort of gendered male-female. We've obviously removed that and gone with a focus on perhaps a therapist of the preference, at least one, the preference of a participant. You know, therapeutic alliance is probably the most important part of the psychotherapy component early on. So the dyad have to work well together. They have to be comfortable. We are going to run with a lead therapist and sort of a secondary. But yeah, there has to be this capacity there for the therapists to, I guess, make their own determination around how engagement's progressing, and also for the participant to speak to that as well, for their voice to be heard. I'm not sure if that answers.
Hi, thanks for that. I'm glad to see. I saw at first I thought there was a bird in there, and then I was like, no, it's actually it's a light. That's good.
Ooh, that could be, yeah.
I was actually just going to ask about the functional MRI that was in that, and particularly about the fact that it's pretty expensive and quite a lot of burden on participants, given the sample size won't actually allow you to do anything particularly meaningful with it.
Okay. I guess I will say up front that I'm probably not the right person to speak to about that in such detail. Functional fMRIs are definitely not my thing. Look, we're adding it in there because I think it's, most studies are, and we've got the capacity. I think it's good to have the pre and post. But I mean, even, I guess, speaking to more the side of it that is my thing, we're already thinking about level of anxiety for a participant who's potentially under the influence going into a machine for 45 minutes or whatever it is that it takes. So I absolutely take your point. Yeah, and you know, even things like we don't want to be doing the qualitative interview on the same day because that's a really massive burden on someone. Yeah, but I think it would be, given we have the capacity, it would be remiss to leave it out.
Okay.
Yeah.
Thanks.
Yes.
Thanks for all the questions, everyone. I assume there's more for all the speakers on Zoom, and I'm just making it up here, but we'll collate them and get them to the presenters to answer after the conference. Next up, we have Dr. Brendan Clifford talking about dexamphetamine for methamphetamine use disorder baseline characteristics of the Lima study sample.
Jack. There I am. Thanks today. So I'm presenting just the baseline characteristics of a study that we did using lisdexamphetamine as a possible treatment for people with methamphetamine use disorder. The Lima study is a large NHMRC funded study, and I just wanted to acknowledge the large and very collaborative investigator group that we were very lucky to work with. So lisdexamphetamine is proposed as an agonist type therapy for methamphetamine dependence. So other types of agonists such as dexamphetamine and methylphenidate have shown promise previously. They decrease withdrawal and cravings and have been shown to increase retention and treatment. More recent Cochrane reviews have showed the need for more recent research. Studies have previously been underpowered and underdosed as a kind of a trend, and so we've gone with a pretty high dose of lisdexamfetamine in our study, which was supported by a safety trial that we did. Lisdexamfetamine is a prodrug of dexamphetamine. It's licensed for use in ADHD and binge eating disorder to 70 milligrams. It's metabolized to dexamphetamine in the red blood cells, which cleaves off a lysine molecule from the lisdexamfetamine and turns it into dexamphetamine. This should reduce its abuse liability in terms of it. There's no advantages conferred in terms of drug liking if you inject it. It also has a slower onset, a lower peak concentration, and a longer duration of action, which possibly offers some advantages therapeutically. So the LEMA study is a randomized controlled trial in a 1-to-1 ratio. We had a placebo, it was double-blinded, at fixed dose, a multi-centre trial. We had sites set up in Newcastle, Sydney, Adelaide and Melbourne. Our inclusion criteria were pretty heavy methamphetamine use, so greater than 14 days out of the previous 28 for at least 12 months. And we had a dosing regimen of 15 weeks with an induction period of 150 milligrams, a 12-week regimen of 250 milligrams or placebo daily, and then a reduction phase of 1 week of 115 and a further week of 50 milligrams. The study objectives were the efficacy of lisdexamfetamine and the safety at this much higher dose, along with those secondary objectives that you see there along the lines of craving, withdrawal symptoms, retention, and some harm reduction measures as well. We were able to recruit our first participant in May of 2018. And our last participant was in December 2021. So obviously that covers the period of the pandemic as well. We were able to recruit 155 participants into the study who had received at least 1 dose of lisdexamfetamine. 97 of those were before the onset of the pandemic, which we count as the 20th of March 2020. There were 21 participants enrolled at the time of the study. After we introduced some COVID-related modifications, and then in December 2020, started recruitment again for another 37 participants. What I'm presenting today are the characteristics of that baseline cohort. So we had a median age of 39. So again, an older cohort. 60% of the sample were male. And we had a significantly large proportion of the population was not heterosexual. I'd forgotten to put those little stars in. Our social demographics are pretty interesting, given, on the back of what the other speakers have spoken about in terms of socioeconomic status and social connection. And our sample, when you look at it, it's diverse, so it's both. So we've got high rates of social disadvantage, but also people that are pretty well off. So we've got nearly half the sample didn't complete high school, but also 20% of a university degree. Similarly, when it comes to employment, 20% of the sample is in full-time employment, and over 50% are on a pension or some kind of income support. 17% own their own home. I do have stars for this as well, actually. And just looking at the sample of homelessness, it's 0% homelessness as in our demographic data. However, one of the entry criteria for the study was being able to safely store your medication, given it was a Schedule 8 medication. Other data sources indicate that about 10% of the sample was precariously housed or at risk of eviction. So there is that, again, that high socioeconomic need there. 75% of the sample had high levels of social support. So there was 25% of people, again, that had no one they could talk to. Our measure that we used was, do you have somebody to talk through problems with, that kind of question? And again, it shows that kind of need for a biopsychosocial approach to the pharmacotherapy delivery. It was also a cohort that used methamphetamine quite a lot. So our median use was 24 days out of the previous 28. Severity of dependence was the score of 10 as the median, or the mean. Half the sample injected methamphetamine use. And age of first use was a median of 21, but quite a big range there as well. The median duration of use for the sample was 16 years. And also, significantly, 40% of the sample scored positive on a screener for symptoms of childhood ADHD. So again, we'll involve that in our analysis as well. So I just wanted to conclude with just noting that we were able to successfully recruit 155 people, high levels of methamphetamine use in terms of frequency and duration. It was a socially diverse sample with high levels of disadvantage. And we've planned subgroup analyses for those COVID cohorts and for those ADHD cohorts as well, and looking at social support specifically. All right, I'd like to thank the participants, as well as the anonymous client that gave Nadine the idea to do the study in the first instance. A big thank you to the site coordinators. These studies don't happen without the great footwork of research nurses like Theodora, who's in the room today, and I think some of the study coordinators are joining us online as well today, so I really wanted to thank them, and to thank our funders, including St. Vincent's.
Do we have any questions in the room or on Zoom for Brendan?
Nadine is up next, so if there's anything thorny, ask her and not me.
There's just one question. We've got Chris Tremonti online today joining us, and he'd like to know when we're going to be able to see the results.
I'll take that on notice and let him be the first to know.
Okay.
Yeah.
And I think Nadine will be introducing some of those early results next, won't she?
Cool.
Thank you.
Okay. Next up, we have Professor Nadine.
I'm sorry, I'm just going to have to bend the microphone. I can't keep up with you. I'm short. Thank you, Brendan. Thank you, everybody, for being here again. I'm going to go really quickly because we're a bit behind time. So that's me. I'm just going to introduce the Lima investigator team. I'm not going to read everybody out, but this is, as Brendan pointed out, a really huge collective effort that has been going on now for many years. If we start in 2014, I think we started with the pilot study. We've been doing this for a while, so thank you to all the collaborators as well. We've gone through what lisdexamfetamine actually is. We've gone through who enrolled in the trial, 155 people. And I'm just going to go straight to the safety data. So that's all you're going to see today. I'm sorry, Chris Tremonti, we don't have actually the final findings of whether it works or not. It's in analysis, and we do hope to have that out early in the new year as well. Is kind of, I'm starting to put a date on it. So, but we will go through the safety data because that's important. We are talking to collaborators in other countries that are also launching on this kind of intervention approach, and they really do need the safety data to be able to use medication at doses that are at least 3 times what the medication is approved for in terms of ADHD and binge eating disorder. So adverse events, we divide into the lisdexamfetamine group. So these are these are the known adverse events, if you like, and Vyvanse is the drug company name, so the drug companies are doing the research. So you can see the kind of things that you'd expect: dry mouth, decreased appetite, headache, maybe some anxiety, and decreased weight, which is something that we have been tracking as well, jittery feeling, initial insomnia. So they're the kind of things we know lisdexamfetamine and pretty much any stimulant will do to you. We've gone through the early pilot study, which Brendan mentioned before, earlier in 2015, 2016, and at that time there were no important safety signals. We did know that one person withdrew early, and Walter Ling reminds us we do need to interrogate those early withdrawals really carefully, and we will be doing that in the RCT as well, because that's where you might capture things that you otherwise wouldn't capture in the people that stay longer. The only serious adverse event we had in that study was someone that had suicidal ideation on the last day of study drug at the thought of not having any more study drug or not being part of the trial. So everything else was mild, moderate and expected. Of all these primary outcomes and secondary outcomes that Brendan presented, I'm just going to talk about the safety data. We did just collect adverse events that were reported spontaneously to the research and nursing staff. We also looked at cardiovascular parameters, particularly blood pressure and heart rate. I didn't show you from the pilot study, but there was a slight increase in systolic heart rate and blood pressure in the open label study. We did serial ECGs, pregnancy testing, detailed medical review at the large study visits, so they were at weeks 5, 9, and then the primary endpoint of week 13. We also, because of the previous serious adverse event, did do a sequential Columbia Suicide Severity Rating Scales, as well as the hostility and psychotic subscales of the Brief Psychiatric Rating Scale and Insomnia Severity Index. In total, we had just over 500 adverse events, the majority of which were mild and some moderate and 10 severe, and sort of reasonably distributed between the two groups. I'll go through them in more detail here. The most, I've lost my arrows there. I had little circles of it. So the most common ones that we saw in the lisdexamphetamine group that weren't in the placebo group were nausea and headache, and the vascular disorders, the primary reason for that was hypertension. We had 5 total discontinuations due to pregnancy, 2 people, 1 in each group, and treatment emergent adverse events, 1 psychosis in each group, and this unusual heart failure that was detected in 1 person on lisdexamphetamine that was picked up by one of the study nurses who noticed this sudden weight gain and orthopnea. The lisdexamphetamine was ceased, abstinence was obtained from methamphetamine, and all the investigations were normal and it resolved spontaneously, and we don't know if it's a COVID-related effect or what that was, but it is in the lisdexamphetamine group. We had no SUSARs, no serious, unexpected and related adverse events. We had 4 expected and possibly related to study drug and 5 unexpected and unrelated to study drug adverse events. So in the placebo group, the things that we saw were schizophrenia, enterocolitis requiring hospitalisation, bipolar disorder, so pretty much what you'd expect in this kind of group of people to appear at some point. Similarly in the lisdexamphetamine group, cellulitis requiring surgery, suicide attempt unrelated to methamphetamine or the drug, accidental benzodiazepine opioid overdose, accidental GHB overdose, and psychosis as well. We will present those in more details in the paper. This the hostility, suspiciousness, hallucinatory behaviour, unusual thought content items of the Brief Psychiatric Rating Scale, and I'd caution you to not look at this as an outcome measure other than safety, because this is conducted by the medical staff on the long reviews, but we know with this scale there is quite a lot of inter-rater variation, so we're just looking here at safety. And there's nothing to me particularly of concern. There is a little bit of decreased suspiciousness in the active group at week 5. I don't think that has any safety concern for me. Insomnia Severity Index, again, nothing kind of significant between the two groups there. Columbia Suicide Severity Rating Scale, also nothing too different between the groups. Again, these are safety measures. Don't see them as outcome measures. It's just safety. So we're not flagging any safety concerns there. We will be back with more detail on the cardiovascular parameters, because we do know that particularly the US audience is interested to see what happens to the blood pressure and heart rate. But we do conclude that this was a safe and well-tolerated medication in people who were dispensed the medication either weekly or twice weekly. Happy to take any questions that I can answer other than does it work?
Thanks, Nadine. Last up, we've got Mr. Liam Akerson talking about not going well today, am I? Lixdexamphetamine for the treatment of acute methamphetamine withdrawal. Thanks.
Thanks everybody so much for the opportunity to speak today. I'm going to be presenting the results from our pilot clinical trial looking at lisdexamphetamine for the treatment of acute methamphetamine withdrawal. And before I go any further, I would of course like to acknowledge the wonderful group of people who are behind this project. It is a team effort every time. I would also like to acknowledge the traditional owners of the land and acknowledge that the work that I'm presenting today was actually conducted on Gadigal land. And we have no relevant conflicts of interest except this study was funded by NCCRED. So, as we all know, when somebody ceases or cuts down on regular methamphetamine use, they tend to go through a withdrawal syndrome. What's really important about this is it's actually really, really common, with up to 97% of people who regularly use amphetamines going through this characteristic withdrawal syndrome. It's also really significant. Although not medically dangerous, it elicits some really significant discomfort, and this tends to be front-loaded during the withdrawal period, with the most intense symptoms being within the first 7 days. Unfortunately, the easiest way to alleviate these symptoms is to use more methamphetamine. So what that means is that if we don't treat withdrawal symptoms adequately, this can lead to a cycle of repeated use. There are currently no approved treatments, pharmacological or otherwise, for the treatment of methamphetamine withdrawal. That being said, there is strong evidence for agonist treatment approaches for other substances. For example, buprenorphine for opioid withdrawal. Now, I'm not going to go through lisdexamphetamine in detail because Brendan did that for us. What I will just say is because dexamphetamine is the active component of lisdexamphetamine, we can look at previous literature which has shown that dexamphetamine can reduce withdrawal symptom severity and craving. Because of this, we think that lisdexamphetamine is a really good candidate medication because it can reduce withdrawal symptoms and craving, but it's also got a really great safety profile. So to test this, we conducted an open-label, single-arm pilot clinical trial of a tapering dose regimen of lisdexamphetamine. Our primary aims were to determine the safety and feasibility of this approach, and we conducted it in a single site at St Vincent's Hospital in Sydney. Our participants, we had a really, a pragmatic and broad approach to our recruitment. So they had to be 18 years of age and they had to be presenting to inpatient withdrawal services for the treatment of methamphetamine withdrawal. But we didn't have any kind of minimum or maximum use parameters there. They had to, however, meet the DSM-5 criteria for methamphetamine use disorder. And really importantly, because we want to focus on that acute withdrawal syndrome, they had to have last used methamphetamine within 72 hours of their first planned dose of the study drug. Our withdrawal criteria were, again, similarly broad. The most notable one is we excluded people who were expected to have concurrent withdrawal from other substances. So we didn't mind if they'd used it recently, but we were just worried if there was going to be a concurrent withdrawal syndrome that was going to affect the quality of the data that we got out of this and also the safety. Our intervention was a tapering dose regimen of Lisdex, where we started at 250 milligrams on day 1, reducing by 50 milligrams per day until they received 50 milligrams on day 5. This was conducted across a 7-day admission to hospital, with the first 5 days as the treatment phase, and then an additional 2 days at the end. And this was to allow our participants to discharge completely stimulant-free, if they so desired, and also to allow us to observe any potential for rebound withdrawal, which is something that we've seen in other medications. We also followed up with our participants once a week for 3 weeks post-discharge. Like everybody else here today, our study was affected by COVID. We conducted it through 2021, ward closures and all, but we did manage to recruit 10 participants to this study. Our participants were on average 37 years old, 9 of whom were male and 1 was female. Our participants had been on average using methamphetamine for the last 13 and a half years. And over the last 28 days prior to admission, they had used on average on 23 out of those last 28 days. And on a regular day of using, they used about 0.6 grams of methamphetamine per day. So it's quite a high using population that we picked up here. We had a pretty even split between people who were smoking and people who were injecting methamphetamine. And we also noted some recent substance use, high rates of GHB and cannabis, but interestingly, no recent opioid use. In terms of feasibility, we pre-screened 38 people for this study, and we enrolled a quarter of those. Our recruitment was open for 126 days because of COVID, but during that period, we managed to recruit one participant about every 2 weeks. In terms of safety of this medication, we found 17 adverse events which were potentially causally related to the medication. The most common reasons for these were gastrointestinal issues, headaches, and trouble sleeping. Really importantly though, all of these were grade 1 or mild severity. So this means they didn't really require any intervention to treat, and they self-resolved. They were really, really mild. We did have one serious adverse event, but that was not related. It was a pre-existing shigellosis infection, which we diagnosed throughout the study. In terms of the hemodynamic parameters, which are again something that people are very, very cautious about when we're giving stimulants, especially high-dose stimulants, what we can see is that there were no significant changes in heart rate or blood pressure across the intervention. They received their first dose of the medication on day 1. And although it looks like heart rate and blood pressure may have dropped, that's probably due to the fact that people had really recently last used methamphetamine, probably still under the effects of that, and that's why their hemodynamic parameters may be a little higher on baseline. We retained 8 participants to the end of treatment, which was our primary endpoint. 2 participants left early. Both of them said that it wasn't due to withdrawal symptoms or the medication. One said it was due to legal reasons, and the other one because he had a history of recent incarceration, and he found that the unit was re-traumatizing to him, which is something really important for the feasibility of these kinds of studies going forwards. The medication, however, was highly acceptable to the participants, especially those who finished the program. Rating average satisfaction in terms of the global satisfaction subscale of the treatment satisfaction questionnaire at 100% at end of treatment, which was really great to see. We also didn't have any missed doses or any refused doses. Now, this is a small study, and obviously we don't have any efficacy measures. But at the end of this trial, we did exit interviews with all of our participants. So to put this into a little bit of context, I'd like to share some of our participant experiences of the medication, how it made them feel, and kind of what they thought about its place in treatment. So this first participant, when we were talking about their experiences with this medication and how it compared to their other withdrawal, said they felt extremely good. Like normally I would crash and burn and I'd be asleep for the next 4 days, which I wasn't. I was the total opposite. And when talking about specifically the effects of this medication and what it did to them throughout the treatment, Pat said, "I've been shocked at how effective it has been. I just have no cravings. I feel completely normal. I've had an appetite. I've been socially active in here. I've been reading, which I haven't done in a fairly long time. It's been awesome." And finally, we really want to know if the participants thought that this kind of approach, just dealing with the acute withdrawal syndrome, had a place in their treatment journeys. And what they said was that, the initial days of coming off methamphetamine, it takes a toll on the brain and body. So the first 5 days are very crucial to longer-term sobriety. It's put me in a more positive mindset. And another participant said that they really believe in this. This is the type of drug that will 100% help with withdrawal, 100%. So what can we take away from all of this? Well, we've shown that in an inpatient population, lisdexamfetamine is safe and feasible for the treatment of acute methamphetamine withdrawal. There are, of course, some really serious limitations with this pilot study, including small sample size and a terrible gender imbalance. That being said, we were able to show safety despite using doses 3 times higher than previously indicated for any other use. And our recruitment rate was comparable with other studies in the field, which was very good considering we did this one with no active recruitment. We just picked people up as they were calling the service seeking withdrawal. We had a highly acceptable treatment based on participant feedback, who described not only a personal benefit to the treatment, but also a belief that this could help others. And future directions, well, we're already in the process of planning a multi-site randomized control trial to show efficacy of this medication. And because of its really great safety profile, we're also thinking of moving it into outpatient and ambulatory withdrawal contexts. Thank you so much.
Any questions for Liam?
Hi, I was just interested, do you have a comparison for people who weren't on the program, who'd gone through the normal withdrawal processes in terms of their level of satisfaction rating with the...
No, we don't. So the questionnaire that we used is specifically focused for investigational medicinal products. So we're not asking questions about the unit so much. We're more asking questions about how the medication made them feel, medication side effects, stuff like that. So no control group. However, a lot of our participants who had withdrawn previously kind of drew their own self-comparisons in the qualitative interviews.
Hi, thanks for that. Sean Popovich from QNATA. Just curious in relation to what Brendan mentioned earlier on as well, around the high proportion of participants in that study that had childhood ADHD. Really stood out to me. I wonder if you'd had looked into that for your participants at all, and if you feel that that might have implications for the future.
Not specifically in this trial, but it is a well-known phenomenon, and there are people who really focus their research efforts around the comorbid undiagnosed ADHD and stimulant use disorder. If you look up someone called Frances Levin, who works at Columbia University in New York, she's got a great body of work around that kind of comorbid ADHD stimulant use thing that's going on. Thank you.
So thanks everyone. That was a great first session, and a first session that I'm highly interested in. One of the overall philosophies or focuses that I love about NCCRED is research into practice, and I think that's the takeaway for me. Just a quick story. So I'm also very grateful to NCCRED because I'm the lived experience member on the panel, and sometimes, to be honest, that can feel a bit token. But at NCCRED, it hasn't been. I've been well included in the process, which has been fantastic. But the thing that's happened over this last year is with the rise of TikTok, we have a TikTok page, right? Yeah, it's kind of crazy, but we've amassed like I think it's nearly 50-something thousand followers. So from there, a lot of those people have converted to our weekly email newsletter that goes out once a week, and there's about 5,000 people receiving that, and I think it's roughly, from the brief information that we have, it's about half of those family members and people that use drugs and alcohol. And one of the biggest things that comes back is we get a lot of phone calls and a lot of emails off the back of the newsletters is people screaming out for something different from what we've been talking about here today with pharmacotherapies, and just a different way of trying to find some change around their methamphetamine use, contrary to what we have available at the moment. So my final thoughts is, like, if there's any way to speed it up and hurry up, I think we'll have some good uptake. So appreciate everyone being here for this session. It was fantastic.